Hello, and welcome back. This is Dr. Rockhold returning with a discussion of pharmacotherapies available for managing opioid dependence and withdrawal. I'd like to set the framework for that discussion by introducing this as opioid overdoses, the epidemic before COVID-19. And to emphasize the relevance of what has been termed the opioid epidemic, as of February 22nd, 2022, a total of 930,811 persons in the U.S. have died of the COVID-19 pandemic, whereas in 2020 alone, over 91,000 individuals died from an overdose of an opioid. And between 1999 and 2020, a total of 932,799 have died, more than have died from COVID. I hope you will agree that understanding the significance of opioid dependence and withdrawal will be essential to reducing this horrific impact on our society. I think to frame opioid dependence and withdrawal, we should start first from an understanding that repeated ingestion of an opiate drug rapidly induces tolerance to the acute actions of that drug. And this introduces first the concept of tolerance, which can be defined as a progressively reduced effect of an opioid on a fixed dose, or requiring a progressively increased dose to maintain the full effect of the first dose. With specific reference to opiate drugs, we also need to understand cross-tolerance. This occurs when a person tolerant to one opioid usually shows at least some tolerance to different opioids. However, when it is desired to rotate from use of one opioid to another, differences in potency become very important. There are opioid conversion charts, such as the one shown here, that allow you very readily to calculate approximate doses for a second agent that may be needed in your patient. Despite this, it can be challenging to calculate how much of the new opioid needs to be administered, in part due to differences in the degree to which tolerance may have developed to the initial agent. It's meaningful to point out that tolerance to ethanol and other sedative hypnotics does not occur to any meaningful degree to opiates. Physical dependence, another characteristic, is recognized as the phenomenon as occurring when you see a unique withdrawal syndrome to an opioid. Somatic, excitatory, nervous activity, these are often very unpleasant and characteristic of withdrawal from a dependence, physical dependence on an opioid. There is also psychological dependence, which refers more to the craving for an opioid. It's often profound, and it is a major component maintaining addictive behaviors. A second major component maintaining addictive behavior is the desire to avoid the distress of the physical withdrawal. And from that slide, we can recognize that one of the great challenges about opioid pharmacology is generated by the extremely unpleasant withdrawal phenomenon that occurs in dependent individuals following discontinuation of chronic use. To see what that looks like, I can recommend this description by a physician named DeRope of withdrawal from opioid dependence. While it is a little dated, it is striking. It illustrates the timing for and degree of distress that can be seen in withdrawal from severe dependence. And it also illuminates the origin of some terms that are often associated with opioid withdrawal. So I will quote from this document. About 12 hours after the last dose of morphine or heroin, the addict begins to grow uneasy. A sense of weakness overcomes him. He yawns, shivers, and sweats all at the same time, while a watery discharge pours from his eyes and inside the nose, which he compares to hot water running up into the mouth. For a few hours, he falls into an abnormal tossing, restless sleep known among addicts as the yen sleep. On awakening, 18 to 24 hours after his last dose of the drug, the addict begins to enter the lower depths of his personal hell. The yawning may be so violent as to dislocate the jaw. Watery mucus pours from the nose, and copious tears from the eyes. The pupils are widely dilated. The hair on the skin stands up, and the skin itself is cold and shows that typical goose flesh that in the parlance of the addict is called cold turkey, a name also applied to the treatment of addiction by means of abrupt withdrawal. Now, to add further to the addict's miseries, his bowels begin to act with fantastic violence. Great waves of contraction pass over the walls of the stomach, causing explosive vomiting, the vomit being frequently stained with blood. So extreme are the contractions of the intestines that the surface of the abdomen appears corrugated and knotted as if a tangle of snakes were fighting beneath the skin. The abdominal pain is severe and it rapidly increases. Constant purging takes place, and as many as 60 watery stools may be passed in a day. 36 hours after his last dose of the drug, the addict presents a truly dreadful spectacle. In a desperate effort to gain comfort from the chills that rack his body, he covers himself with every blanket he can find. His whole body is shaken by twitching, and his feet kick involuntarily, the origin of the addict's term, kicking the habit. I've included this slide particularly for those of you who enjoy visual learning particularly. This cartoon simply illustrates many of the somatic effects of opioid withdrawal, and you'll note that it uses several of the terms from DeRope's description that we just heard. The slide here is intended to give you a little bit of the history of the so-called opioid crisis in the United States. And it's pretty obvious that as a nation, we've responded poorly to opioid use disorders historically. In the epoch from 1999 to the present, we can actually identify 3 separate waves of significant opioid abuse. In the early decade, pharmaceutical marketing and a belief among medical professionals that pain needed to be treated aggressively by opiates contributed to a fairly striking increase in the rate of prescription opioid overdoses. Some of this has been traced back to a letter of a single paragraph that was published early in this period and which led to the impression that managing pain in individuals with opiates limited, if not completely avoided, the possibility of the contribution to abuse and addiction. The letter that I just mentioned and a critique of the medical community's response to that letter is available, and you can access that through the link that is shown in this slide. I think you'll find it instructive. The second wave of opioid crisis that occurred, shown here as number 2, occurred as the medical and law enforcement community began to act to reduce the opioid overprescription to patients who were already dependent on prescription opioids. As a result of the limitation of availability of prescription opioids, those people who were dependent began to turn to street drugs, particularly including heroin. And during this period, it's also been documented that the illicit production and introduction of heroin into this country increased dramatically during this period. And then finally, in the most recent period, which started about 2013 and which continues to this day, we attribute to a flood of illicitly produced fentanyl and fentanyl derivatives. These have been documented to come largely from Asian suppliers, primarily mainland China, and this has led to a dramatic spike in overdoses that continues to this day. An understanding of this history begs the question of how providers can respond to these concerns and which pharmacologic tools are available to those providers. In general, as a nation, we've attempted to limit access to drugs that enter by illicit or illegal means by introducing abuse deterrent formulations of opioids and by trying to manage the unpleasant symptoms of opioid withdrawal that complicate the ability to move patients away from opioid abuse. That latter plan involves something you're aware of called medication-assisted treatment, or MAT, which refers to the use of certain opioids, particularly including methadone and buprenorphine, as well as the selective use of opioid antagonists to assist patients in the management of opioid use disorder. You need to recognize, because of the impact of the opioid crisis, healthcare providers are being increasingly scrutinized by professional organizations, by the media, by the public, but particularly also by law enforcement agencies with respect to the use of opioids in their practices. Pertinent examples of these and the organizations to which you will be responsible are shown on this slide. The UMMC Opioid Task Force, the last of the 3 shown here, was initiated several years ago by Dr. Woodward explicitly to inform and guide our educational and clinical approaches to opioid use and misuse. That Opioid Task Force presented our last report to Dr. Woodward this past month. In the next couple of slides, we'll look at each of these agencies in a little bit more detail. First, looking at the federal level, the U.S. Drug Enforcement Agency, DEA, has established controlled drug schedules to categorize drugs with abuse liability, and providers must obtain a DEA license in order to prescribe these agents. There are 5 levels, Schedule 1 through 5, that are categorized by the degree of abuse potential in a drug and whether or not that drug has a current and legitimate therapeutic use. Examples for each of these schedule levels are provided. Schedule 1 agents cannot be prescribed, and they can only be accessed legitimately for research purposes, and this requires a separate DEA license from the one normally provided to providers. Requirements for prescription writing, submission of the prescriptions, and the number of refills are specifically identified for each of the drugs in the different schedule levels. And you will be required to apply for your DEA provider's license before you begin practice. In Mississippi, additional oversight for the use of not only opiates but also benzodiazepines was established by the Mississippi Board of Medical Licensure in 2018. Part of those rules require providers to monitor the Mississippi Prescription Monitoring Program, PMP, which can be accessed online, before writing an opioid prescription. It introduces a term, the morphine milligram equivalent, or MME, that is used to allow dose levels of different opioids to be compared. Important notes that you should recognize are that, first, acute pain should be treated with an opioid for only short periods of time. Chronic, non-cancerous, or non-terminal pain should be treated with as low a dose of opioid as possible. And specifically, if a total MME exceeds 100 MMEs per day, that the patient receiving the prescription must be referred to a specialist in treating pain. This slide is simply an infographic that gives you a more detailed explanation of the morphine milligram equivalent per day term. You're going to become much more familiar with the relative amounts of opioids that you prescribe, but you should recognize also that there are many online MME calculators that are available and that you can use to make that calculation. I think the salient points here for you as a provider are to keep the dosage as low as possible to control pain, because there is a strong statistical correlation between opioid dose and the risk for both overdosing and death. And to reemphasize key points from the previous slide, first, try to keep your daily doses of an opioid below 50 MMEs per day. Don't use more than 90 MMEs per day for chronic non-cancer pain. And remember that you are legislatively mandated to refer a patient to a pain specialist if they are being prescribed more than 100 MMEs per day. The next couple of slides are going to be used to introduce opioid drugs that are used specifically for medication-assisted therapy. First, methadone, which is marketed as Dolafine, but is also available as a generic compound. It is marketed as a mixed enantiomer containing levomethadone, the L enantiomer, which is a synthetic full agonist at the mu-opioid receptor, and dextromethadone, the S enantiomer. Most of the clinical effects are believed to be due to the mu opioid receptor agonist actions, but antagonistic actions by dextromethadone at the excitatory glutamate NMDA receptor may also contribute to the beneficial effect of this compound. Turns out that methadone is more slowly metabolized than is morphine and can usually be given only once a day, and in medication-assisted therapy, it is given as an oral solution. While methadone in itself is an opiate and it has excellent analgesic actions, currently it is used primarily to manage the opioid use disorder, either to maintain patients and prevent withdrawal, called maintenance therapy, or in a managed detoxification inside a clinic environment. It does have subjective euphoric actions, but these tend to be relatively less intense than those produced by morphine, particularly after oral administration, so that its abuse liability is considered to be less than that of other full mu-opioid receptor agonists. It is important to recognize, however, that abuse liability is not zero with methadone, and there is significant illicit use of methadone. While it has characteristic opioid adverse effects, recognize that methadone also can prolong the cardiac QT interval, and this can lead to ventricular arrhythmias and death. Next, we're going to look at buprenorphine, which, as you can see, has multiple formulations. It is a drug in the mixed agonist-antagonist class, and it has the receptor profile noted in this slide. As you can see, in addition to effects on the mu, kappa, and delta opiate receptor, it is also a partial agonist at the nociceptin or FANN-FQ receptor, or NOP. It's currently used extensively in medication-assisted treatment for opioid use disorder. In that context, it will prevent abrupt opioid withdrawal when substituted for a full opioid mu opioid receptor agonist, but it generally gives less euphoria than a full agonist would. With this, a patient can be somewhat more easily weaned from use of that full agonist that the patient may be abusing. Recognize that in some of these formulations, buprenorphine is combined with the opioid antagonist naloxone. These latter formulations are called abuse deterrent formulations and have proven necessary because buprenorphine alone in large doses can be and is abused. The abuse deterrent combinations with the antagonist naloxone are effective because naloxone is inactive orally due to extensive first-pass hepatic degradation. Thus, a formulation with naloxone has no antagonistic action when given as an oral or sublingual medication with buprenorphine. However, if such a preparation containing the naloxone is dissolved for IV injection, then the naloxone misses the first-pass metabolism. It can exert its full antagonistic effects and will usually send a chronic abuser into an acute antagonist-induced withdrawal, limiting the desirability of going that route of administration. Because both buprenorphine and methadone are opiate agonists and can be abused, there are very specific regulations controlling which drugs can be used for medication-assisted treatment. Buprenorphine, for example, requires that you get a federal waiver before you can prescribe the drug for opioid use disorder. Methadone, clinics which dispense methadone must be federally certified and accredited to be able to dispense methadone for opioid use disorder. On the other hand, naltrexone and naloxone can be provided by any prescriber, and usually a narcotic antagonist is made available to individuals who are being treated with MAT for an opioid use disorder as a rescue medication should they, so to speak, fall off the wagon and go back to excessive and inappropriate use of another opiate. For those patients who may be in acute opioid withdrawal, there are some things that we can do to help ease their suffering. During withdrawal from dependence on an opiate, sympathetic activation can be significant, as you saw particularly from the cartoon and the description earlier. Diaphoresis, tachycardia, muscle tremors, piloerection are frequent, and nausea and vomiting are also very severe. We can manage this somewhat, at least, with drugs like the centrally active alpha-2 adrenoceptor agonist antihypertensive clonidine, or Catapres, which has sedative properties, reduces central sympathetic outflow, and can ease the distress of patients undergoing opioid withdrawal. Lofexidine, Leukamyrna, is similar to clonidine and was recently approved for use in managing withdrawal. And then promethazine, or Phenergan, is a neuroleptic with histamine blocking properties. It's a very effective anti-nausea agent, you already know that, and it can also help ease some of the symptoms of withdrawal. So let me finish up this section with these take-home points. We have to recognize that opioids are unexcelled at acute pain management, but there are significant concerns about tolerance, dependence, and abuse increasingly limits the use of opioids in the clinical environment. We do have true antidotes that exist, naloxone, naltrexone, as well as some of the peripherally restricted narcotic antagonists that we described in earlier lectures. Available, very helpful. And then when we think about cross-tolerance, opioid rotation, we need to recognize that there are significant differences among the dose regimens for different opiates and among the pharmacokinetic disposition of these that have to be taken into account when you are considering using one opiate as opposed to another in any particular clinical situation. I appreciate your attention. Please feel free to send any questions you have about this material to me by email, by phone, or come by my office. Thank you very much. Goodbye.